Good morning or good afternoon, everyone. It's my pleasure to welcome you all to this GVHD Interactive Provider Network, which is sponsored by the Aplastic Anemia and MDS Foundation. It's my pleasure to host you here today. I'm Cutler. I'm the Medical Director of the Transplant Program at the Dana-Farber Cancer Institute. And today I have the pleasure of being accompanied by Dr. Kirsten Williams from Amar University, who is our expert in bronchiolitis obliterans, and Dr. Amar Kelkar, who's an attending physician here at the Dana-Farber, who will be our case discussant. So the goal of this program is really to connect us and you, GVHD specialists and people with special interest in GVHD. This is really about learning and mentorship, and we offer an opportunity to interact even after this program is done. So by all means, please feel free to reach out. From a continuing education point of view, the target audience here is for all transplants clinicians, be it physicians, nurse practitioners, or PAs, healthcare professionals, including pharmacists who treat chronic graft-versus-host disease. And the educational objectives are shown here to identify the optimal approach to screen for bronchiolitis obliterans, to discuss treatment options, and to review supportive care needs. So here is our agenda for this morning. Once I'm finished with a few housekeeping slides, Dr. Williams will present the background of bronchiolitis, followed by Dr. Kelkar, who will present cases, and then we'll have time for open discussion. Here are our disclosures. Dr. Pavletic, who is not with us today, has the following, and my disclosures are here on the bottom of the slide. Dr. Williams and Dr. Kelkar's disclosures are shown here. Finally, I want to acknowledge our sponsors and our partners. Both the National Bauer Donor Program and the Meredith Cowden Foundation have been instrumental in helping get this program up and running. You should all know that we are recording this, and by participating, you do consent to that recording. I have to tell you that. What we do suggest is that you please keep your camera on, but stay muted during the presentation. By all means, raise your hand and I will be monitoring the chat. We can interrupt the lecture or the questions if something important comes up. And with that, we will jump right in. So you're all here today to speak about bronchiolitis obliterans. We know that this is an uncommon but exceptionally important complication of allogeneic stem cell transplant. It presents often far too late because we don't screen correctly for this disease, and it takes a while until patients are symptomatic. We don't understand a lot about this disorder, but Dr. Williams will shed some light on that. And again, the reason why this is so important to speak about is because it is really one of the most important causes of attributable mortality in chronic graft-versus-host disease. So not to take any more time away from Dr. Williams, I am going to pass the slides over to her, and for the next 20 to 30 minutes, she will teach us all about bronchiolitis obliterans. Kirsten?
Thank you for the opportunity to present here and be part of this. We went over this already. So as Dr. Cutler just presented, bronchiolitis syndrome, obliterans syndrome has actually had significant challenges in terms of making progress, in contrast to some of our other manifestations in chronic graft-versus-host disease. Originally, and still, this is really quite a rare disease, which is a challenge. And the risk factors for BOS are actually quite common among our patients. So it's very difficult to isolate the patients who have an increased risk. The diagnosis used to require morbid biopsies. Patients, as you pointed out, are often diagnosed late. And those who are diagnosed in non-invasive techniques require PFTs, which is an infrequent test. The lung is a relatively inaccessible site in contrast to the skin or the gut, where we can certainly do more biopsies and other sorts of things. And it's a relatively poorly modeled disease in mice, although we've certainly tried, and some strides have been made in that as well. And historically, it was highly fatal, which also was a real challenge to understanding this disease and how to improve it. So we have made some progress over the past little over a decade, I would say. And there's been a great deal of increased awareness in the disease. You can now diagnose it non-invasively. There's better screening. We're certainly promoting more frequent PFTs. There are novel methods on the horizon that are pretty exciting that might allow us to diagnose this without PFTs, which certainly would be very helpful for our patients. We've borrowed a lot of information from the lung transplant literature, very similar diagnosis to this, which has really allowed us to develop some novel therapies. And certainly other advancements in chronic GVHD have also promoted the advancements of other new exciting therapies that may have a role in BOS. And finally, great strides have been made overall in supportive care of chronic GVHD and in BOS patients specifically. So currently, BOS is now diagnosed predominantly by pulmonary function tests for most of our patients using the modified NIH consensus criteria from 2014. As you can see here, this requires an FEV1 less than 75% and a decline of greater than 10% per year, and certainly from pre-transplant PFTs. The absence of acute infection at the time of diagnosis, although certainly suspicion can be there, the presence of another chronic graft-versus-host disease manifestation, and then evidence of obstruction. So obstruction used to be diagnosed by an FEV1 over forced vital capacity ratio less than 0.7. And now we appreciate that, that this will actually both over and underdiagnose patients at the extremes of the age spectrum. So actually we recommend that people look up what the ratio should be for your individual patient to see whether or not they are outside the confidence interval for that ratio and therefore have obstruction. This is especially important for younger individuals because our ratio actually declines with age from a ratio of 1 when we can first do PFTs. To a normal ratio of 0.6 in the elderly. I've listed the website here. There's a couple of different websites, but this is just one of them that can help you find the confidence interval for your patient based on age, ethnicity, et cetera. This just shows a cartoon spirogram that really shows what the PFT findings of BOS are. As you can see here, the healthy patient, which is most of us on this call who don't have obstructive airway disease, can breathe about 80% of our expiratory volume out within the first second, and then the remainder in just a few more seconds with a low residual volume remaining. Whereas patients who have BOS can breathe less air out in the very first second, take longer to breathe air out as a whole, and then actually have more residual volume remaining. I actually thought you were going to hear the cases first, but I'm going to highlight some of the things that you'll see in the cases that I think sort of help drive home these points. And one of them is that one of the patients actually may have met criteria for this, and she's quite on the border. And I actually put her things into CDC, making up a few heights and so forth. And so I think this really does highlight that we may have an opportunity to diagnose patients earlier if we do use the confidence interval of the ratio. Air trapping is no longer required to make the diagnosis. And in fact, we now appreciate air trapping as seen on CAT scan can be a late finding in BOS. So we don't want to rely on that, but it can also highlight that a patient might have BOS, which actually you'll see on case study 1. And what the air trapping is really a diagnosis of a mosaic pattern on the architecture of the lung. So you should really have black lungs at the top going to a grayscale down. This is because, of course, there is some atelectasis in the base of your lungs, which is created by gravity. What you can see more predominantly here in the patient who's quite severe is that there are large areas of very black lung at the bases. And so that really is characteristic of air trapping. There are other nonspecific findings that can help you prompt a PFT, things like bronchiectasis, ground glass, pneumothorax, all of which can be helpful but nonspecific. Sorry. So this is a diagnosis of exclusion. That's one of the things that makes it challenging. Our patients can have a lot of lung problems after transplant. They can have restrictive lung disease for a variety of reasons. They can actually have cryptogenic organizing pneumonia, often in the setting of an infection. This is really has a characteristic pattern on CT of a consolidation, and these patients respond very nicely and rapidly to steroids, which really can distinguish the two sets of patients. You can have radiation fibrosis, often later than BOS, but not necessarily. And this just shows a CT finding of that. And again, imaging can be very helpful for many of these things. Patients can have extrinsic compromise, things like sclerotic chronic graft-versus-host disease of the respiratory girdle, or I even had one patient who had GVHD myositis of her respiratory muscles specifically. So it is important to try to separate out an intrapulmonary from an extrapulmonary process. There are rare diseases. I've actually diagnosed 2 cases of alpha-1 antitrypsin, and this is a simple blood test to send, and 1 case of tracheomegaly. So tracheomegaly patients have a very characteristic notch on their PFTs, which is just worth noting. And finally, infection, which is, as we know, a great confounder, unfortunately. As Dr. Cutler mentioned, diagnosis is very challenging in these patients. It's very difficult to get frequent PFTs. We recommend every 3 months for the first year, and then every 3 months for the first year after diagnosis of chronic graft-versus-host disease. And I think in the aftermath of COVID, probably many of us are experiencing workforce challenges, fewer technicians, and inability to get these tests. So I certainly appreciate that, but I am hopeful that we will get back to a point where we can do them. I have up in the corner a patient who actually had air leak syndrome from a biopsy, and just sort of demonstrates why it's so important to make the diagnosis by PFT. What you can see is actually every plane in her body was actually lit up, had air in it with massive crepitus, and it took months for her to recover. The average patient is diagnosed with moderate disease, which just shows how much we need earlier diagnostic techniques, with a median FEV1 of 50 to 50%. And I think both patients will highlight this, that, you know, if we could do more frequent PFTs, and if we really could do these things, perhaps these patients would be diagnosed at an earlier time frame. So as I said, the risk factors for BOS are common. So this is really a challenge. And you'll see that actually both patients had busulfan preparative regimens, peripheral blood stem cell transplants, as do many patients we treat. Viral infections are very common post-transplant. The great majority of patients with BOS will have an identified viral infection within the first 100 days of transplant. And severe acute GVHD, again, sadly still relatively common event. And one of these 2 patients had this as well. So there are new exciting things on the horizon to diagnose BOS early and easier. There was some data looking at FEF 2575, and I would encourage you, as you get PFTs in your patient, if you see a decline in this, this is a marker of early BOS in lung transplant, and I think certainly would merit close following your patients with more, even perhaps more frequent PFTs, or certainly making sure that they are one of the ones that gets the Q3 month. And then Dr. Chang out of Seattle has an R01 multi-center study now looking at handheld spirometry. So this is really exciting. It's a device you can take home. It performs, the patients breathe into it just as if they were performing PFTs. It captures the amount they breathe out at 1 second, or FEV1, in the amount of 6 seconds. So FEV6 creates a ratio. And many of these devices are set up in such a way that this can be transmitted to a pulmonologist who can review this and then can trigger PFTs. And so, you know, really exciting for these data. Certainly the early data are suggesting that this would be an opportunity to catch these patients early. And, you know, patients, since it's in their home, could perform these even weekly. And I think really identify a new decline. Out of University of Michigan, Doctors Galvin and Yannick have been working on parametric response mapping. This uses a CAT scan and requires an inspiratory and an expiratory CT at the same time. It is performed by taking the expiratory CT, which is of course smaller because you've exhaled, and increasing it using a computer so that it's the exact same size as the inspiratory CT. You then overlay the 2 CTs. And they are divided up into something that is like pixels, like the picture on your phone, which they term voxels. And each voxel can determine whether the amount of air going in and out is normal based on that black grayscale I talked about on the earlier CAT scan, because of course you should have very black lungs at the top, and then have some atelectasis that moves forward as you go down, and based on gravity. And so this can allow you to determine whether or not the air going in and out is normal in that field of the lung, in which case this would be identified as green. Whether or not the air going in is normal, but the air coming out is abnormal, that would be obstructive disease in yellow, or whether both entry and exit of air is impaired, which would be parenchymal disease as shown here in purple. And And this has actually been very sensitive in a number of lung diseases, including BOS. Dr. Yannick has recently been funded for this in a multi-center trial out of NIH. And this just shows here how you could use such a thing. And so this patient here on the far left has normal lung, and you can see here that the great majority of their lungs is shown in green. You can color code both each slice of lung, and you can also have a plot that looks almost like a flow plot. So here, this patient has infection after 60 days after transplant. You can't probably read this, but 32% of the lung actually has parenchymal disease. 3% is obstructed and the remainder is normal. The third patient here has bronchiolitis obliterans syndrome. This is a diagnosis. This patient actually has 39% of the slice of lung that is made up by obstructive disease. And 13% is parenchymal, with the remainder being normal. And then finally, this is a patient who has BOS and infection. And you can see here that 28%, or about a third, is parenchymal disease, 40% is obstructive disease. And so I'm hopeful that this will both be a way that we could identify patients earlier with BOS and then also follow them in a more sensitive way than PFTs. Xenon MRI is also an exciting modality to potentially both identify and follow patients with BOS. There are some benefits to MRI. As we know, it does not use radiation. I have been told that sometimes this is a slightly more difficult test to perform, although frankly, I haven't performed it myself. There are some biomarkers that may be on the horizon. These have been linked to BOS after HCT, including MMP3 and MMP9. These are metalloproteases. The lungs do use metalloproteases in injury and repair. So it's not terribly surprising and certainly biologically rational that these would be elevated. And as you can see, these studies showed that these were elevated in patients who had BOS more than patients who had chronic GVHD without lung findings, and certainly more than patients who didn't have chronic GVHD at all. And both of these studies really looked at established patients. So we don't yet have data to find out whether or not these would be elevated before clinical symptoms, before patients are clinically identified. And there's also some good news on the horizon in terms of treatments and outcomes with BOS. I took all the studies that were published prior to 2009, and I created a Kaplan-Meier curve. So this actually represents a number of studies together, most of which actually were treatment studies showing benefits. So I think, if anything, perhaps captured the best of that historical cohort. And the 4-year survival was 44%, and the 5-year survival was 20%. So then looking at some larger studies that looked at outcomes involving a variety of modalities, again, taking large sets of studies, there's certainly a marked improvement, basically a doubling or more of outcomes in patients in the modern day who have BOS and chronic GVHD, although clearly this curve is still quite divergent from the patients who have chronic GVHD without BOS. So as Dr. Cutler pointed out, this is still a risk factor for death, and we still do have strides to make. So the first trial I actually undertook in this disease was a trial to use montelukast, or leukotriene inhibitor, to treat BOS after HCT. And this study did include a lot of immune correlates, which is really my primary reason for presenting it today. Like many studies, patients had significant disease at the time of enrollment on the study, 46%, and many patients actually had been living with BOS for some time, with a median of 3 years. We saw some modest improvements on the study. About a quarter of patients had greater than a 5% improvement in FEV1. One child had a maximum of 14% improvement in FEV1, which, by the way, is why I'm a pediatrician. Children always do best. But the great majority of patients experienced no change on study. We did see improved patient-reported outcomes in responders. We did see improved slope. We borrowed the use of the slope from the COPD literature and the gold standard. And then we did see some interesting things in terms of immune correlates. There is a publication in lung transplant BOS that looked at patients who did not have infections, and they saw elevations in CD4, CD8, and macrophages as compared to healthy controls. and actually fewer granulocytes. We saw that same pattern in our patients who were uninfected. This represents 13 people pre-treatment uninfected. We did actually further look at these CD4 cells and saw that the great majority of them were actually Th2s, which fits with some murine and other data. We did look at leukotriene levels. This was in 24-hour urine collections, much thanks to the patients who did this. And we saw that 45% of patients had elevated leukotrienes. This is LTE4, which is the final common pathway of leukotrienes. As compared to healthy controls, this is a standardized CLIA-certified test. And patients who had more severe disease did have higher leukotrienes, suggesting that leukotrienes may be part of the mechanism of BOS. This study and others, largely in lung transplant, but a few in HCT, prompted us to undertake the FAM trial. This shows the biologic rationale for the study. This includes inhaled fluticasone that would directly locally impair inflammation and fibrosis, montelukast that could impair fibrosis through leukotriene receptors and impair homing of activated cells to the lungs, and azithromycin that could block IL-8 and diminish neutrophil infiltration. These were newly diagnosed patients. It was a multi-center study. I did have central PFT review. We did enroll 36 patients. All adults, and again, median enrollment of 46% FEV1. And we saw actually not too dissimilar results from the montelukast trial. And essentially, we did see that about a third of the patients actually had a decrease in their PFTs. About a third had an increase in their FEV1 of greater than 5% at 3 months, and that seemed durable at 6 months, with maybe even capturing a few more patients with improvement. This did result in steroid sparing, so patients were able to come off steroids. Few actually had an increase in their immunosuppression, and this was associated with less than 20% of the successes. And there was good overall survival and few adverse events on the study. So the conclusion was that this was safe and well tolerated. It stabilized the majority of patients at this early time point. It was associated with steroid reduction and improved patient-reported outcomes. It may offer benefit to newly diagnosed patients. And I think it is considered the standard of care for newly diagnosed BOS in both the US and EU at this time. There were some follow-up reports that suggested azithromycin may have some concern that this might be linked to cancer. I'm just going to mention these. I think personally the jury might still be a little bit out, but I think overall the risks of BOS probably exceed the risk of these. And the first was a randomized trial of 480 patients, where half of these were randomized to azithromycin. This was pre-transplant in patients with high-risk leukemia. And at that point, I think that the jury is no longer out, that there isn't benefit to employing a preventative approach with azithromycin. So there was an increase in relapse in this group. I'm not sure that the group was perfectly matched, as most groups aren't in terms of risk factors for acute leukemia. But two other studies suggested there may be a concern. One by the same group in Seattle looked at a retrospective study. This is post-diagnosis of BOS, so obviously a different risk factor for relapse. They did not find an increased risk of relapse, but they did for secondary cancers with the use of azithromycin. And then another group who found out of 1,300 patients, 13 were exposed to azithromycin and did have an increased risk of relapse if ATG was concurrently used. Two studies have suggested there's no increased risk. These are retrospective studies, one presented in abstract form at ASBMT. So obviously we do personalized medicine for every patient, and you should weigh the risks and benefits. I think for the great majority of patients, progressive BOS probably does exceed the risk of relapse or secondary malignancies, but again, individualized approach. There's some new data out on the horizon using a ROCK2 inhibitor. This is some very nice data. It combines two prospective trials. As we know, this is the Rho-associated coiled coil-containing protein kinase 2. This can lead to inhibition of this can lead to a decrease in Th17, which has been linked to BOS pathogenesis, and an increase in Tregs, which has been helpful for chronic GVHD as a whole. In these two prospective studies, 59 patients had BOS, and the overall response rate was 32%, with about half of them actually receiving a full, that should be a CR, sorry, not CD. In addition, there are a couple other therapies that have been tested. Many patients do benefit from restarting either a calcineurin inhibitor or sirolimus. In basic in vitro studies, sirolimus actually is more protective of lung cells, although I don't know what that particularly means otherwise, and may have some benefit in Tregs. The overall response rate for etanercept of all published trials is 33%. Many of those are retrospective, but a few are prospective. Etanercept is a prospective trial, 33%. ECP is retrospective and prospective. Combining all together is 60%. And this is the exact same response rate also in lung transplant BOS, which is rather interesting. There are two ongoing trials that I'd like to highlight. One is a CSF1 receptor inhibitor. This really attacks alternatively activated macrophages, which are thought to be part of the mechanism in BOS and have been supported in a couple of different trials. And then a neutrophil elastase inhibitor, which again could block sort of neutrophil migration and infiltration. To date, ROX and Ritux haven't shown benefit, although again, these are relatively smaller studies. I think when we look at the case, one question would be, would there be a benefit of starting, would there be a benefit of starting sirolimus back or a calcineurin inhibitor as well, or considering one of these other therapies. I just wanted to summarize all of the therapies and sort of where they hit the different pathways in terms of the biologic rationale, and where they might be beneficial, so that you could also potentially see which ones might be synergistic. I think it's pretty exciting that this is now our current landscape, when in 2009 it was really pretty much steroids and calcineurin inhibitor. So I think we've made a lot of strides. For patients who are refractory, lung transplant does remain an option, and there are newer data that patients can have good outcomes and don't necessarily have recurrent BOS. And so I think for many patients, the current treatment algorithm is to start with FAM, consider restarting Siro. And then for patients who progress, I think there's great data for ECP. There's emerging data for ROC2 inhibitors. I certainly think that should be in the algorithm at this point. And certainly a plea to enroll patients on trials and novel therapies. And then for patients who are truly refractory, to consider lung transplantation. There are some challenges to these trials. The natural history is plateaus and declines. And these are really difficult studies, but I think it's quite heartening that if you look at a decade apart, in 2008, there were 2 trials for BOS, and in 2018, there are 44. Supportive care is really, really critical in BOS. GERD is a risk factor and may worsen disease. There's even literature for Nissens in this patient population, but certainly treatment of GERD is critical. Nutrition is often sort of forgotten because patients are so ill, but they need nutrition, and being catabolic does not improve outcomes. Certain drugs can actually worsen this disease, and albuterol can transiently help, but I did have one patient who was on albuterol continuously for weeks. This can lead to bronchomalacia and actually worsen the disease. You can even see it on the bronchoscopy. Pulmonary rehab is very important. You want to avoid beta blockers and ACE inhibitors because these can cause respiratory symptoms. Obviously, correct anemia. Don't overcorrect anemia, but correct it. And then I've had many, many patients that I've actually diagnosed with methemoglobinemia who came to me with BOS and were hypoxic. I'm just going to make a small plug that there is an emerging other form of chronic GVHD called restrictive lung disease, which really is a primary vascular parenchymal problem, again, similarly occurring late. And there, unfortunately, are no confirmed diagnostic criteria, but these patients do have a decline in DLCO, a decline in FEV1 with a normal ratio, and evidence of some air trapping. They often have fibrosis on upper lobes of their CT. And really, I think there's sort of unknown incidence, although in 2 retrospective groups that I've looked at, the incidence is about 10% of patients with chronic GVHD. There are studies that link it to allogeneic transplant, that the incidence is 70% in allogeneic and transplant compared to 20%, 25%, sorry, in auto. There was an association, particularly in children with GVHD and with pre-transplant pulmonary dysfunction. I think there's a lot to be learned and studied in this patient population. And I do think it's important to look to see if your patient does have restrictive disease and also chronic GVHD, and really to think about this. There is sort of an equivalent diagnosis in the lung transplant literature called restrictive allograft syndrome or restrictive CLAD, which certainly provides sort of added credence. And those patients do have a B-cell infiltration and some linkage to poorer overall survival with increased IgG, supporting that B-cells might be more of a mechanism in this disease. To my knowledge, only one drug has been used for this. This is a prospective trial out of Michigan where they used etanercept, and they included patients who had lung dysfunction after bone marrow transplant that was obstructive or restrictive. And this is a very nice study with some nice evidence to suggest that TNF alpha might be part of this. I think ninatinib, which I can't really pronounce, but this drug might be more beneficial in this disease. Finally, infections, both are probably culprits in CLD genesis and also plague our patients and our ability to really treat them well afterwards. They often occur, as we know, BOS often occurs after a viral infection in the first 100 days. RLD is linked to aberrant B-cell immunity. And our ability to diagnose infection is a moving target. So I think we might find that more patients actually have infection prior to the diagnosis of these diseases now that we have more sophisticated ways to actually diagnose these infections. So I think we know we can now do PCR on BAL. This has improved the detection of PJP or PCP, Aspergillus, and viruses. There are new next generation sequencing tests and carry us on the blood. And I'm sorry, this slide does still say Explify from BAL, but University of Washington does this on BAL. And these are highly specific and sensitive, and I think really maybe of value for our patients. And when people have looked at patients who have BOS, including myself, in my study, 1/3 of asymptomatic patients where we obtained CAT scans, did PCRs, blood cultures, and all of this negative for them to enroll, 1/3 of them had infections by BAL. And we actually treated them and then repeated their PFTs before we started montelukast. And 1/3 of those infections were mycobacteria, which is a highly deadly bacteria in BOS patients. So I think I just make a plea for anytime you see a patient who has a decline to really do a pretty impressive look for infectious etiologies. And there's a very nice workup in one of the cases, but I think maybe to consider NGS testing or other sort of sophisticated testing in these patients may be valuable. And then and just not to forget prophylaxis and treatment for these patients. They should have PCP or PJP prophylaxis, fungal prophylaxis, especially if they're exposed to steroids, penicillin and or azithromycin for bacterial prophylaxis, maintaining an IgG level above 500 for good bacterial protection, as well as viral prophylaxis. And just, in addition to early influenza, I would now include early COVID treatment. Patients who have bronchiectasis are likely to be colonized with gram-negative organisms. There's some very beautiful basic data that came out of NIH for that and may benefit from some CF type treatments. And finally, just a note that because these patients can have significant air trapping, chest x-ray might not be useful as this can really hide infections. So in summary, I think we have two recognized forms of chronic GVHD, I would say at this point. The workup really includes PFTs, BAL to rule out infection and other causes. The standard of care treatment currently, I would say, is FAM plus or minus recurrent sero or calcineurin inhibitor. And then there's a lot of emerging secondary therapies that are quite exciting. We still need diagnosis and therapies for RLD. And currently our best diagnosis and response really does rely on PFTs, but I'm quite hoping that changes in the future. and supportive care, including treatment and prophylaxis for infections and nutrition is critical. So finally, I think this is the current state of the union in chronic GVHD. It does still confer significant non-relapse mortality. Lung decline is a key risk factor, and we've made progress with steroid-sparing agents, but there's a lot to be done. And I really hope that those of you on this call both look out and help diagnose and help us screen for these things, but also really consider contributing to trials and contributing to work to advance this for our patients. I'd like to acknowledge a number of people, specifically my collaborators in Seattle, at University of Michigan, NIH, the Lung Chronic Graft-versus-Host Disease Consortium, the NIH Chronic Graft-versus-Host Disease Consortium, and the patients who made this work possible, and you for your attention. Thank you.
That was by far the most comprehensive lecture I've actually think I've ever seen on chronic GVHD and lung involvement. So thank you for that, Kirsten. There haven't been any questions yet. I've been monitoring the chat. So I think, again, I encourage everyone to chime in, unmute yourself, turn your cameras on. But if there's nothing right now, we'll proceed right over to the prepared cases, and Dr. Kelkar will present them, and Dr. Williams will be our discussant.
All right, well, thanks so much. We'll get started here. So the first case here was of a 67-year-old gentleman, history of MDS with high risk disease. He was transplanted with the reduced intensity conditioning PBS-CT from the donor with the MASH unrelated donor transplant. He received Flubu-2 with TAC and methotrexate for GVHD prophylaxis. At day 77 after his transplant, he had CMV reactivation that was able to be resolved with just a course of valacyclovir and developed a brief course of acute GI GVHD starting day 110 after his transplant that resolved with corticosteroids alone and a taper. At approximately day 171, he started developing symptoms of oral GVHD with lichen planus features seen. You can see an example here on the left with a photo. And it was just managed locally with cevimeline and dexamethasone rinses. He eventually was tapered off his tacrolimus by day 265. His oral GVHD symptoms were relatively mild, and so he'd been doing quite well until a little bit later on in his course when he started developing progressive dyspnea for about a 2-month period. Started very mild and really wasn't picked up even with asking the patient questions about this until a little further along in his course. It progressed to quite labored disease, including shortness of breath, even with short walks on flat ground. This was occurring with concurrent development of a non-productive cough for approximately 5 weeks at the point when we started evaluating it a little more closely. He did have a rise in his eosinophil count concurrently up to approximately 3, as well as some negative infection testing, including a negative COVID PCR, as well as a negative galactomannan. When we obtained a high resolution CT, we did see some evidence of air trapping and bronchial wall thickening, seen here with some of these hypoattenuated areas with the arrows. And then when we got his post-transplant PFTs around that time, we saw that his FEV1 had decreased to about 53% of predicted compared to 94% pre-transplant. His ratio at 0.57 compared to 0.77 pre-transplant, and a DLCO of 75%, which is also down. So in terms of management, we resumed his tacrolimus since it had been a relatively short amount of time since he had gone off of that medication, as well as initiating prednisone. We didn't really notice much of a significant response subjectively in terms of his symptoms, as well as by PFTs. And so we initiated FAM therapy and tapered him off the prednisone. He did have some improvement, including it very similar to the studies, a small, about 5% improvement in his FEV1, but it progressively worsened again over time. And he eventually went on supplemental oxygen. we screened him at that time for the axatilimab clinical trial. This was the CSF1R inhibitor that Dr. Williams presented earlier, but through the screening process, the patient felt it was too onerous and decided to decline. And so we got him onto belumosudil. He did not show a further improvement, but it did seem to stabilize his course at that point, but he remains on oxygen and at least at this point still alive. Dr. Williams, I didn't have any specific questions here to start out, but I was curious how you thought about the management and what guidance you might have in terms of where we might have thought of different things.
Yes, no, I actually, I think I put in my slide that I was sad the patient did not go on the CSF1 receptor inhibitor trial.
Mm-hmm.
You know, I do think there's quite a bit of data. It's all sort of correlative data to suggest alternative activated macrophages are involved, but you know, a lot of these things are linked to alternatively activated macrophages, Th17, Th2 cells, and even leukotriene. So there's quite a bit, actually, I think, sort of peripheral data. So I have to say, it saddened me that the patient didn't choose to go on that trial. You know, I think it's tough. The decision of whether or not to restart the calcineurin inhibitor or the CRO, it's a tough one. I would say about half the patients that I've treated, we've restarted, largely in the setting of other chronic GVHD manifestation flares and things like that. And I don't think there's any data to really support that you should or shouldn't. I do feel like some patients get a benefit, especially from CRO. Again, feelings are not really what we should be. We need data for this, right? And I think on FAM, I think half the patients had it too. So I had them restarted. So I think it really becomes challenging to know whether or not that is of benefit. And a lot of patients also have not tolerated those agents well, right? So some have had things like press or TMA or other sorts of reasons why there's hyperglycemia and so severe hypertension. So I think, again, these are all risk benefit things. My suspicion is if the patient declined the CSF1 inhibitor, he probably would have also declined ECP, which I think there's probably, also good data for. Right. And then, I think the nice work that was recently published on the ROCK2 inhibitor, certainly is now in my armamentarium of sort of sequential therapies. I tend to do them in that order just because that's the overall response rate. I'm not sure patients who are this far out are going to benefit from etanercept anymore. I suspect that, if TNF alpha is involved, it's probably earlier in the cascade. That being said, a third of the obstructive patients did respond on the prospective trial with a range of FEV1. So I think all of those, and then supportive care would be my other thing. So.
Absolutely, and I didn't highlight that specifically here, but definitely that's something that we got the patient involved in pulmonary rehab, and certainly some of the other things that you mentioned in your talk would be things to consider and to improve this patient's care.
That's great, Dr. Cutler, that you're going to do a phase 2 trial with the drug I can't pronounce, but the ROCK2. You'll note I haven't pronounced it yet. Yeah. I don't know. Should we answer the other questions or should we?
Yeah, why don't we, between the first and second case, Dr. Schultz had a couple of questions he wanted to pose, and then we'll go back to the second case.
Hi, guys. This is a great presentation. I'm really enjoying this. But a couple questions, Kirsten, you didn't, as far as I can recall, mention ibrutinib as a potential therapy. And I've heard anecdotal stuff, but I don't know all the literature and just any comments on that. And then the other question I had was just on diagnosis. You didn't mention MBW as a diagnostic tool and wondered where you thought it played a role.
Yeah, so thank you for highlighting MBW. That's actually a misstep. I just wrote it down. So this is work that comes out of your group, and it is fantastic and especially important in pediatrics. So I definitely need to get a slide in on that. So for those of you who are not pulmonologists, which is probably most of us on this call, multiple breath washout is a pulmonary technique where the patient can breathe normally. So in contrast to the regular pulmonary function test, they don't have to do a forced exhalation maneuver. So a big deep breath in and then a forced exhalation out. This maneuver is really difficult for children. It's actually really difficult for adults. If you've never done PFTs, it's worth doing once. So instead, multiple breath washout basically lets you breathe pretty normally, and it will measure the air exchange through something called the lung clearance index. And this can give you a pretty sensitive marker as to peripheral lung disease. And the study is very nice. It's recently published. I recommend everyone look it up. I think first author was Stanovich. I'll put it in the chat, or you can put it in the chat, Dr. Schultz. But it's a great paper, and I think really MBW may be a great way to increase diagnostic sensitivity in our patients. So I think it still does require a trip to a PFT lab, to my knowledge, and the lab does have to be set up for it. So actually in our own institution, which has 2 large pediatric hospitals, only one has the capacity to do the MBW. But many centers do. So I definitely encourage looking into your center. And the MBW test is used in a lot of other pulmonary diseases, and therefore like cystic fibrosis and things. And so therefore the pulmonary group should have expertise with it and the ability to perform it for your patients. And I'm excited to see more data come out. I think we should do more studies, but the first one is quite good. In terms of ibrutinib, so this is such a good question. You know, B cells play such a critical role in so much chronic GVHD. I mean, there's just extraordinary, excellent studies that really support this in the mouse models, in the patients, and yet, interestingly, the data for the role of B cells in BOS is less, it's less robust. You know, even in my BAL samples, no one had B cells. There were no B cells. And this is fascinating. That doesn't mean they're not involved. It just means, you know, we couldn't see them. And when people tried Ritux and other B cell blockade agents, they did not show, thank you for putting, oh, and I'm sorry, I said the wrong author. So thank you for putting that in. But anyway, when patients have tried these other B cell therapies so far, I think they haven't really showed benefit in BOS. That being said, the data for ibrutinib is, as you said, really anecdata and small. And I think, you know, on the major ibrutinib trial, I think there were 2 patients with BOS. So you know, I think the role of ibrutinib in this is an unanswered question. I do have more enthusiasm for other agents that have sort of a biologic rationale that fits with what we know about the disease, but that doesn't mean it wouldn't work. I think, you know, certainly I would be pro also testing a BAL fluid for other markers to see whether or not ibrutinib might really play a role here.
Thanks.
Great questions. Amar, how about we go to the second case?
Sounds great. All right. So case number 2. This was a 48-year-old woman with AXL1 mutated AML, treated originally with 7+3 and 5+2, followed by venetoclax and azacitidine, who got into a CR2 and was transplanted with a myeloablative PBSCT from a haploidentical donor, receiving FLUBU4 conditioning, and then PT-Cy, TAC, and MMF GVHD prophylaxis. She was CMV positive herself. Donor was negative, but there was no reactivation after the transplant. She did have very mild stage 1 acute cutaneous GVHD starting day 77 after the transplant that resolved with topical betamethasone. And was off immune suppression after day 244 from her transplant. She had her 1-year PFTs at day 360 with an FEF 25 to 75% of 80% predicted, with FEV1 of 71%, and the ratio of 0.75 with the DLCO of 63%. After crossing that point, she started, about a little over a year and a half into her transplant, she started developing a non-productive cough, just noted increased generalized fatigue, daytime napping, and some weight loss as well that I didn't mention here. And she had, and we noted an increase in her ferritin previously from about 1201 back at day 120 up to about 2586 at 1 year, and it remained high even at this later time point. We did a little bit more extensive infectious workup in this patient, as Dr. Williams had alluded to, with CMV titers, galactomannan test, and COVID testing, and a respiratory viral panel as well, to kind of exclude other causes, and also repeated her PFTs at that time, and saw further decline in several different categories, including an FEV1 that had declined to 39%, a ratio that had declined to 0.46. The FEF had also declined from about 80% down to 58%, and DLCO had declined as well. And there was minimal response to bronchodilator on testing. Similarly, we also got a high resolution CT in this case, again, seeing air trapping and evidence of bronchiectasis on the CT. And so we initiated first line therapy in this patient, a FAM, again, using a prednisone taper, with subjective improvement in symptoms, but no change to her PFTs. And so this is where I wanted to pose this question to Dr. Williams of where might you go in this patient with next line therapies here? We've certainly discussed nintedanib with our pulmonary colleagues to see if we might try to get that approved. We've thought about belumosudil. We've thought, we considered ruxolitinib, and I think you presented as part of your presentation that may not be a good option here, or consideration of clinical trials like axatilimab, but where might you advise us to go here?
Yeah, I mean, I think these are great considerations. The Rux data is also sort of confusing. Again, there's fantastic data for Rux in chronic GVHD as a whole, and so I think as of yet, I don't think there is compelling data that it has made inroads in VOS. Again, I would say sort of the same caveat about ibrutinib. Jury is probably still out on that one. I think there are probably better choices. And one thing I would say, this one I probably would consider bronch more strongly. And I say that because this patient does have bronchiectasis. And so the greatest likelihood is that there is some gram-negative colonization, and that the patient can also have intermittent sort of exacerbations in the same way that sort of COPD or CFRs do. And knowing what the bugs are can really help, I would say. And some of the patients I've treated, I've even done the sort of 1 month on, 1 month off inhaled Toby and things like that. Again, there's no formal data for this, but certainly we have seen improvements in those patients and fewer gram-negative pneumonias after we started those regimens. So, albeit with the caveat that, of course, you can breed resistance, and the ID docs are not extremely excited about these kinds of approaches. But I agree. I mean, for this patient too, I think in the absence of any other signs of chronic GVHD, sero or calcineurin becomes a hard choice. I do think using the ROCK inhibitor or trying to get them on the CSF1 receptor trial would be probably my kind of go-to, or ECP. I mean, the data for ECP is still 60% overall response rate. So it's a hard thing to do, especially for adults. I think in kids, it's probably easier because we can set them up with sort of virtual school during the couple hours per week, but it's a hard sell in adults. So I appreciate that's challenging, but those would probably be sort of my top choices. As I said in my slides, the I can't pronounce that one there. I think this one is probably going to be more exciting for RLD personally. So just in terms of mechanism, I think, really we need to shore up the vessels in the parenchyma on that disease more. And so the mechanism of action of this probably fits, in my mind, at least a little bit better, but jury is still out for that too. And finally, your last box is probably the most important, which is that we're only really going to learn to answer these questions by enrolling patients on clinical trials. So I think as much as we can, both participating in clinical trials and helping get these patients on them is super critical.
Absolutely. And certainly I think having seen, empiric examples from other colleagues of, nice improvement with drugs like axatilimab, I think that's one that we pretty seriously consider here. But thank you so much.
Those are both great cases. So I think we will, I'll share my screen one more time. I would encourage anyone to once again unmute themselves and chime in with a question before we start to wrap things up here.
Oh, can I ask a question?
Please.
Hi, it's Jenny White from Vancouver, BC. Thank you for an excellent talk. I think you kind of alluded to this challenge we all have with the PFT monitoring, and it's gotten a lot more difficult, and we're really kind of struggling not being able to get Q3 monthly for everybody. Are there any particular groups that you would strongly suggest we really push the Q3 monthly, like the established chronic GVHD population?
Yeah, exactly. No, I think we're all having to make these decisions, which is horrible because we don't want to make these decisions. We want to give optimal care to everyone. But I agree with you. I think I would push patients who are newly diagnosed chronic GVHD, patients who have severe acute GVHD.
A couple of quick announcements. Our next lecture in this series will be on November 17th. That will focus on the atypical manifestations of chronic graft versus host disease. And I encourage you to register for that program. In December, we'll have another program focusing largely on supportive care. And if you want to access the 3 prior lectures, they are available online at gvhdnetwork.org. A couple of announcements. The Aplastic Anemia and MDS Foundation will have a webinar on November 4th on bone marrow failure syndromes, and the QR code to register for that is right here. Encourage you to register for that. There are some great speakers there. After the results from the from Be the Match is going to be is now online. So this is understanding the role of transplant for older MDS patients. Actually, CTN 1102, a study that I happen to co-chair. Finally, the Accelerate Forum, for those of you who are in cell and gene therapy, will be happening for 2 days in November 17th and 18th. It's a virtual only conference, and the link to attend the Accelerate Forum is on the bottom of this slide. The Meredith Cowden Foundation will be having a webinar on the 21st, so just this Friday, and again a second webinar in late January. This Friday is on the biology of chronic GVHD, and in January, Joe Padala will speak on drug selection, and there are upcoming webinars from the Cowden Foundation that I encourage you to look out for.